the very kind introductions. I think I would want to steal the limelight of the speakers. So let me quickly introduce the first speaker, Dr. Paeds. Dr. Paeds is a very close friend of mine back in our training days and serving day in University Malaya. Dr. Paeds is a consultant pediatrician as well as a pediatric neurologist from sunmed Medical Center. He was trained as a pediatrician under University of Malaya's master program. Then he continued his training as pediatric neurology in UMMC and further into pediatric neuromuscular disorder in Great Ormond Street Hospital and Dubowitz Neuromuscular Center of London. So he is an excellent medical educator back in University Malaya and a researcher and with many outstanding publications in the ISI cited journals. So he's also the editor of the textbook of pediatric and child health together with Professor Lee and Dr. Lam under the UM Press. So without further ado, Dr. Paeds is going to enlighten us on pediatric TB meningitis, a case-based journey, dilemmas, suspicion, and survival. Dr. Paeds, the floor is yours. Thank you.
Thank you, Rating, for kind introductions. Okay, I'm sorry because there is a switch of the slot, so I will be talking first, followed by Dr. Cheng and Dr. Olive. Okay, I also changed the topic slightly, so instead of giving all the information, probably we will share cases, okay, what have been seen for the last 1 year and the difficulty we have faced when managing this group of patients. Okay, diagnosing TB meningitis is actually quite difficult and it's very challenging. It's not easy. It's not a single test that, okay, one test and then you can make a diagnosis. Why? Because the initial presentation is very weak. Okay, they come in with a very non-specific symptom, just fever, headache, vomiting. And when we only suspected them to have something is not right when they start to have new neurological symptoms, for example, abnormal eye movements or some other focal neurological sign. And the laboratory technique also in general quite insensitive, and you also take a slow time. For example, TB culture, you won't get it within the 3, 4, 5 days, correct? And with the current technology, with the CSF PCR, yes, it helps us a lot, but sensitivity is still not 100%. It can be range from 40 to 85%, and this often leads to a delay in the treatments. So what we are going to do today is to share the cases, and we learn together all the 4 cases we've seen for the past 1 year in sunmed Medical Center. Although those cases come with problem of headache, they also give us headache, and we managed to solve a headache in the end, and they are all go back to a normal state, and they are recovering very well. Okay, these are the cases. So the age group, it ranges from 1.5 to about 10 years old. They present very vague symptoms, fever, headache, vomiting, and then subsequently have abnormal eye gaze. This is why or when we suspected something is not right, it's beyond the normal viral illnesses. And the diagnosis for all the cases, right, we did not manage to get the molecular diagnosis or microbiological diagnosis, mainly based on the histopathological, radiological, and clinical finding. So I'm going to share with you case by case. The first one case, this is a 2.5 years old girl, but previously normal, not immunocompromised. So came in with, presented to us, right, it was 2 weeks ago, have a history of fever. So fever for 5 days, and then admitted to a local hospital for 3 days and treated as UTI. And started on the IV antibiotics, subsequently discharged with the oral ceftriaxone for 1 week. So despite oral ceftriaxone, still having persistent low-grade temperature, the fever is not high, just about 37.6, 37.8, somewhere around. And started to have vomiting subsequently about 1 or 2 times per day. Initially thought that, can it be due to antibiotic? Because taking antibiotic causing some tummy upset. So ultrasound abdomen was performed and then was told normal, so was asked to observe, and the child continued not improving, start to have an eye deviation on and off and persistent vomiting 1 day before admission to sunmed Medical Center. And otherwise, if you look at the child is not too bad in terms of the neurological status. He's still able to interact, walking around, GCS full. So this is how that actually came to our pediatric ED, and then after that, we investigate from there. So on admission, he got multiple episodes of vomiting or projectile. Okay, 2 episodes of eye deviation described by my mother. Of course, I didn't see it. So the child is definitely not irritable. There's no neck stiffness, no other focal neurological sign, no weakness. And based on the projectile vomiting, which is a bit weird, so persistent for almost more than a week already. So we do a plain CT scan and see what's happening. So CT scan show a hydrocephalus. Okay, so if you look at the baseline blood investigations, actually you see the marker all are not high. CRP 2.5, ESR 8, WBC 11. Of course, at this age, we cover with antibiotic, just make sure that we are not missing any bacterial infections. So we arrange for urgent MRI with contrast, so we can see a huge hydrocephalus communicating habit involving lateral third and fourth ventricle, and it was a thick leptomeningeal enhancement around the basal ganglion, around the basal system. Okay, here you can see there are the leptomeningeal enhancement you can see here. All right, around the basal system. And there also a small focal lesion at the posterior aspect of the left medial temporal lobe. So we thought, okay, based on the clinical finding, it looked like the TB meningitis. This is a possible TB tuberculoma. So we proceed with the EVD, okay, and then during the EVD, we did a CSF sampling. To our surprise, normal. So WBC 0. And then sugar is actually quite normal, more than 50% from the serum blood sugar, and the protein completely normal. Our meningitis panel from a CSF all negative. Chest X-ray unremarkable. Okay, no miliary TB changes. And the further history, they say that the grandfather has history PTB, but passed away and not in contact previously. So based on it, okay, are we still thinking, hey, is it TB or not? So we go back to the criteria. There is a TB meningitis case definition criteria published in 2010. So in order to fulfill or to have this scoring system, you definitely need to fulfill 2 prerequisites. First, you need to have a clinical feature of meningitis, which the child had. Second, you need to fulfill the CSF abnormality, okay, which is compatible with meningitis, but we don't fulfill this criteria. So, but we keep in mind, okay, it might say, okay, probably we will watch again, okay, we will continue monitor the child closely, and we will repeat the CSF sampling. Day 2 is still protein is not high. Day 4, protein is not high. Of course, the WBC can be due to some irritation after the EVD insertions. So post-EVD, occasional vomiting, a bit much improved, no abnormal movement anymore, and the low-grade fever persistent. It is not continuous, it just give you 1 or 2 spikes per day, that's all. It's just less than 38 in general. Appropriate interaction, not confused, not irritable, able to sit, but refuse to walk. So this only will come back after a few days later, just about 2 days later. Quantiferon go negative, CSF PCR, TB PCR negative, MEN2 test positive, more than 15 mm. So is it latent or this is the true TB? So because of the child's relative health, okay, we decided, okay, we monitor closely. We want to make sure that we are not missing any other TB mimicry. Want to exclude any malignancy like diffuse leptomeningeal glioneuroma tumor. Okay, we get our big oncologist to review. She doesn't think that this is a tumor. Okay, we also try to entertain neurosarcoidosis. We send some marker, but it takes a long time to receive. Okay, and because of the situation with patient is quite stable, we inserted VP shunts about day 6 of admissions. CSF cytospin, no maintenance cell scenes, and the child still remain febrile from day 7 to day 10. So no headache, no neck stiffness, no vomiting, just a bit cranky when approached, otherwise still playing on the bed, okay, and then can walk a few steps, a short distance around the room. So because of the persistent fever, we decide, okay, the only way to monitor child closely, CSF is not a good way because it's not coming with a very abnormal CSF. So we actually repeated the MI again. So from day 10, we repeat both. CSF, okay, a little bit high. This one a bit difficult to, is it inflammation because of the external, because of we actually do VP shunt, those something causes induce the inflammation or real infections. So, but we keep in mind and then repeat the MRI. Oh, you can see it's such a thick leptomeningeal enhancement around the basal system. Okay, and what the other new finding is there are two small area of restricted diffusions, okay, here and here, okay, at the medial aspect of the bilateral inferior cerebral hemisphere. It just indicate there's infarctions, okay. But what surprised us, the previously seen tuberculoma, you remember this here, disappeared. So it also puzzles a lot, hey, why the tuberculoma disappeared? Okay, we didn't give anything, just IV rocephin, all right? But anyway, we proceed for the second workup, TB workup, CSF. We send to another lab, two different lab, negative. Culture, of course, these are all later. And then we also do the marker like that. Sometimes adenosine, the amylase will be elevated in patient with TB. It was not elevated. CSF chloride is normal. But because of a thick CSF, the thick leptomeningeal enhancement in the basal system, we can't wait anymore. We have to empirically treat the child with the anti-TB and then started the IV DEXA. Okay, and day 14, we monitor and then we repeat the whole MI, just about workout, and we can see there is a light using a marker to draw the line. There's a very thick lepto and diffuse leptomeningeal lying from the entire cord, from the cervical, thoracic, and lumbar regions. Okay. Besides, you also can see there's a small nodular enhancement at the posterior theca sac around L4, L5. So it's very small, about 0.5 cm, very tiny little dot there. So we discussed with parents. Okay, and the good thing is parents consented to get the tissue biopsy. So we managed to get the biopsy. Unfortunately, it turned out to be normal dura, aronoid membrane, no inflammation cells in. And then the TB PCR, tissue PCR, we sent also negative. We thought, okay, could we miss a lesion or not? Now, we will proceed with anti-TB first. We continue to give an anti-TB, and the child responded well. Okay, no fever. Okay, no vomiting. Okay, still remain cranky. Okay, otherwise start to walk around inside the room, and we discharge the child at day 24 of hospitalizations. So 2 weeks post-discharge, came to the clinic for follow-up, start walking, running, still very emotional and tantrums. And then an NG tube feeding, because the child very picky, very difficult to feed. So we have to use, how difficult we are, we have to use an NG tube to feed the anti-TB medications. And 2 months after the post-discharge, we repeat the MI again. Oh, good. Okay, there's a restoration of hydrocephalus. Okay, and then all the leptomeningeal enhancement you see earlier is already improved, and there's a much interval improvement in terms of the meningeal enhancement, also restorations of those high signal changes seen in the MI previously. So we are quite happy, so probably we are on the correct track, but unfortunately, they defaulted follow-up for 2 months. They stopped the anti-TB for 1 month. Okay, they come back again with vomiting, neck pain, refuse to move the neck, disturb sleep, and poor oral intake without fever. So this time we are quite sure something is come back again, correct? So we admit the child immediately and reinitiate anti-TB treatment, started steroid. And then we perform the MRI the following day. So you can see the previously those enhancement, those have disappeared, now it reappear back again. Okay, it come back again. And the leptomeningeal enhancement is, you can use a pen to draw. These are all significant. So although no hydrocephalus, there's a diffuse leptomeningeal enhancement in the basal system, okay, also dural enhancement in the tentorium. So there's multiple high signal changes seen in the MRI, and also thicken of the cranial nerve, especially in around the tracheal nerve, abduction nerve, facial nerve. These are all showing the nerve thickening with the enhancements, and you can see a multiple lymph nodes enlargements. Okay, this now we have to get the proper diagnosis. So discuss with parents, okay, that allow us to do a second tissue biopsy. Okay, so we actually we aim over the cervical region, so did the C1 laminectomy, dural biopsy, excision of the dural lesions, CSF sampling during the process, and also perform the cervical lymph node biopsy. For the second CSF sample, you can see the CSF protein, you can see such a thick leptomeningeal enhancement, but the protein still remain low. Okay, the sugar is definitely not low. Okay, we repeat all the PCR, TB PCR, all come back to be normal. Cervical dural show tuberculogaroma. Okay, subarachnoid tissue, nicotizing granulomatous, cervical lymph nodes, no nicotizing granulomatous lymphadenitis. All these point toward TB. So we also send the tissue biopsy for PCR, but all negative. So from all these things, we conclude, okay, we are handling a true TB meningitis. Okay, so we follow up the child 6 weeks after the second admissions, continue anti-TB. This now parent really adhere to the schedule, continue anti-TB. So very cheerful, tantrum, able to take medications, used to a medication, no need NG tube, repeated MRI. There's interval improvement, and 9 months from the first admission, we repeat the MRI again, complete restorations of all the lesions seen. So currently the child is doing quite well. So you can see diagnosing TB is quite challenging. It's not easy to get the molecular diagnosis as well as all the microbiological diagnosis. Sometimes we still need to base on the clinical finding. Of course, we also have to exclude some of the TB mimicry. For example, some of the rare autoimmune disorder or neuroinflammatory disorder. So as I mentioned, they present with very weird symptom, and then very non-specific, which can mimic a febrile or viral febrile illness. The viral load in children tend to be very low. So that's why it's not easy to get the bacilli, to get the positive bacilli. And sometimes in order to show a sample, we need to have a very large volume of CSF, for example, 10 ml, 12 ml volume in order to detect the bacilli, but which is quite difficult. Exposure to prior antibody might also limiting factor. Sometimes they give like augmentin, those things might partially treat the child. And there is a molecular limitation. So the second case, what I'm going to discuss with you, this is a 9-year-old boy, again, previously well. Okay, he presented with 5-day history of fever, headache on and off, and received just a normal treatment, just a clinic treatment, just a Panadol, okay, and the symptom is not improving. Persistent headache, persistent fever. So admitted here, we treated for mycoplasma infection because mycoplasma IgM is positive. And then despite with the IV azithromycin, child still have a persistent fever. The fever is not like diarrhea high, it's just around 38. It's not 39, 40. and the headache on and off. And on day 3, start to have abnormal eye gaze, okay, upward gaze, and intermittent confusions. They have a neck stiffness, start to have nystagmus, but no vomiting. And on admission, you can see again all the marker during a admission, CRP, ESR, WBC are all not really high. Okay, of course, it was covered with IV rocephin at day 3 just to make sure you're not missing any bacterial infections. And the MRI was performed. There is a mild ventricular dilatations. Okay, there is a leptomeningeal enhancement. And then here are all showing leptomeningeal enhancement. So because of the MRI show a feature of a meningoencephalitis, so LP will perform. Okay, WBC this round is elevated 35, predominant lymphocyte, and the glucose is low. The blood sugar is actually, serum blood sugar is 5.6, and the CSF is less than 50%, and the protein is almost about 1.2 grams. So all the meningitis virology panel, those are all negative. And of course, like usual, we repeat all the TB workup. Again, negative. TB PCR negative, CF from CSF. MEN2 test negative. Quantiferon, the first one intermediate, the second one 5 days later is negative. Trachea aspirate 3 times. AFP or not seen, culture negative. CSF adenosine 2.6, not really high. CSF, all the viral, we also look for other viruses, workup, so all negative. So we continue monitor. The child actually was in the Paeds ICU, was continue monitor closely, and then that time we was thinking, okay, is it TB or not TB? Okay, but my colleague was actually handling a child. So and that during that times I'm away. So they call me and say, hey, got persistent headache, fluctuate GCS, and then start to have photophobia about day 5, and then describe a lot of spider on the neck, and with the nephsenia upward gaze, and EEG of performed, there's no abnormal activity, no seizure activity since. And further history, maternal auntie had a history of TB 3 years ago, was treated. We repeated MRI. MRI showed interval increase in global battle manager enhancement. Okay, so you can see here, there's an increase in the leptomeningeal around the basal ganglion, the brainstem region, and also mild ventricular dilatation. Based on this, I think based on previous history, I think we have to start anti-TB treatment, and then we also give a steroid. 48 hours after anti-TB, the child actually deteriorated, reduced GSS. The puppy skin size positive and was intubated, and then we planned urgent EVD insertions. During an urgent EVD with resampling again, this now the protein almost going back to normal, sugar is not low. Okay, white cell also 3. And I say, now since we continue support in Paeds ICU, okay, and we will closely monitor and repeat the the MRIs the next 2 days. So at day 9, we were unable to wean off the ventilator, so started to vomiting. There's a new neurological sign, weakness of the lower limb. The power is about 1 or 2. And then repeat the MRI, show a brain swelling. So you can see these are all the brainstem, the thalamus here show signal changes. And then the cerebellum, you can see the hyperintensity. Okay, this is cerebellum, you can see hyperintensity. All right, so then now, this with changes, with new change, are we handling TB or not? Are we handling other rare autoimmune disorder? Okay, mimic TB, this is actually really puzzle us. So the child deteriorating. So is it because of we started anti-TB, it create a lot of inflammation, because anti-TB will start killing those mycobacterium and then start to release a lot of cytokine, causing the local inflammation. So there's a lot of questions that we are unable to answer. So we have to be very sure, okay, we do not miss any rare autoimmune meningoencephalitis disorder, although all our panel, ANA, double-stranded serum autoimmune neurology panel, include MMDR, more aquaporin or negative, but we decided to give IVIG because the child actually deteriorate. Because if you don't cover, if the child deteriorate, so really not TB, it can be quite detrimental to all of us. So the child received IVIG. We give a 2-day, 1 gram each day, total 2 grams per kilo. Day 13, still very lethargic, ophthalmoplegia, 2 cysts, but start able to follow some simple instruction. The weakness of the limb remain, reflexes present, start to have some gag reflex stronger, meaning that it look like the strength is coming back. We added on the IV mitaprep just to suppress whatever inflammations. This is a high-dose mitaprep. Day 17, okay, there's a significant improvement in the neural status, start to have an anti-gravity movement. The gaze is no longer upward gaze, is the improved gaze, able to look at us, and we off the EVD and extubate child day 18. Day 23, we repeat the MRI just to check, okay, whether there's any improvements or not. Okay, good news. There is a reduction in the brain swelling. So in the previous slide, you can see this is quite significant. Okay, both are inflamed, okay, and hyperintense. Now it is less. So we continue to support, and then and the child actually show a favorable response and able to walk independently and subsequently discharge at day 27 of her admissions. And we continue anti-TB, and about 2 weeks post-discharge, they come to the clinic. Parent very happy, say that almost 80% back to his previous status or previous pre-morbid state. At 3 months post-discharge, completely back to himself already. So MRI we perform, apart from very mild hydrocephalus, the rest of all the leptomeningeal enhancements are all disappeared. We're still following up the child, okay? So again, sometimes these are all the questions when we are looking at very complex, not a typical presentation, then we start thinking, hey, is it a rare autoimmune encephalitis or is it any other rare infective encephalitis? But I don't have an answer. But at the moment, since the child improving very well, so TB is still more common, so common thing come first. So we still thinking, okay, this is still consistent with TB meningitis. So the third patient, the 10-year-old boy, previously well, attending a Songkran water festival in Thailand, and developed fever for 3 days and vomiting 3 days in Thailand. So because of fever and vomiting, they actually returns immediately to Malaysia and admitted in one of the local hospitals, treated as gastroenteritis. About day 2, day 3, start to develop abnormal I-word gaze, refuse to walk, photophobia, start to have mouth nastiness, 1 episode of urinary incontinence. Day 3, develop persistent vomiting, slurred speech, and then reduced conscious level. So initial, if you look at the blood investigation, very initial is not high. CRP is 2.7, ESR 3, WBC 8.9. So it's covered with IV subtrazone as usual. And we only see around day 3 when the child come to our center. Immediately we perform the MRI. MRI show quite a global diffuse leptomeningeal enhancements. And then it's also mainly over the basal system region. There's no dilated ventricle. Okay, so we perform LP, opening pressure 55, quite high, and blood sugar 7.3. If you look at the CSF, the WB is definitely high, 100, more than 100. Definitely this is some infection going on. Protein is 1.2 gram, and sugar also less than 50%. And again, all the meningitis panel, the PCR, all negative. So as usual, we will do the whole panel of workup when suspecting TB. So TB PCR, again negative. Gastric lavage, PCR, TB negative, sputum negative, quantiferon negative. The only thing is the adenosine deaminase slightly elevated, as it shown as positive. And the mental test negative, and all our virology panel, we screen negative. So based on the previous 2 cases, so I think we probably no need to wait. We start anti-TB treatments. So during a started the anti-TB, this took about 4-5 days. 4-5 days later, we also send the mycobacteria other than tuberculosis, also non-tuberculosis mycobacteria. It turned out to be positive. Okay, and now the issue is, are we handling atypical presentations of this non-tuberculous mycobacterium or not? Because the child is not immunocompromised. So is it really a MOTT? We call MOTT mycobacteria other than tuberculosis, meningitis, or this is a contamination? We can't answer. Since the child is not unwell with a neurological side, we have to treat this element as well. So we added with the IV amikacin. Okay, this is day 3. The child will reduce, but the result was actually came out later. So after the anti-TB, the GCS a little bit dropped, okay, but otherwise the child remains stable, requires some bypass support, not require anti-intubations. There's a post-salivary effort and reduced muscle tone, the power about 4 to 5, hyperreflexia upper limb, eczema lower limb. So therefore, we just want to check again, just to make sure that we are on the correct track. There's no worsening of level, because for them, right, it's very difficult to just based on the kidney sign alone. So we need to have other modality to counter check. Okay, are we doing well? Is the child actually, if a child is not improving, are we still doing well? So imaging is one of it. So repeat, okay, stable. The rectomeningeal aneurysm is not worsening. Okay, it's almost the same. All right. So at least we know. Okay, current treatments, we are on the correct track. So day 8 of admissions, with all the treatments, GCS return, full GCS, able to follow command, able to express, start to grip, start to use a remote control, handphone, able to swallowing, attempt to swallowing, although still on NG tube, but able to swallowing, have a good effort of breathing of our BiPAP support, and day 11 start to walk, mobilize, no feeding issue. Day 20 got issue with some voiding issue, so difficult to pass urine, so we managed to get our nephrologist, okay, and then do a uroflow. It just show obstructed pattern, so give our urologist give some medication, and then we monitor closely. Day 21, because of this, we actually perform whole spine just to see any abnormality, just some patchy leptomeningeal enhancement. We repeated LP again, the MOTT, the first one positive, it turned out to be negative. And the proteins come down for 1.2 gram, is about 300. Then the CSF previously is from 100, more than 100, now it come down to 35. So we continue support and then continue amikacin, IV amikacin, child will discharge day 35. And then post-discharge 2 months later, he remained well, okay, back to his pre-morbid state. So again, these are the questions we're asking. Is this a clinical presentation for MOTT or not? It's very atypical. It is not a typical one. It's atypical. And the other thing is, if it's not MOTT, probably these are all TB meningitis. Okay, the last case. This is one of the younger childs, 1.5 years old, from Cambodia. Okay, they purposely fly to sunmed to receive treatments. Presented with low-grade fever for 4 to 5 days, persistent vomiting, abnormal eye gaze, very cranky, okay, poor oral intake, sleep, very tired. Mommy say keep on sleeping most of the time, refuse to walk, people start walking but refuse to walk, and then 2 days before coming, start to have convergent screen. On arrival, irritable, lethargic, bilateral signal palsy. We look at the optic by the papilloedema, temperature 37.6. Again, it's not high grade, just a very low grade temperature. So when we look at MRI, this MRI, ventricle is like slightly dilated, and there's the diffuse leptomeningeal enhancements, and also there are signs of showing that the increased intracranial pressure, so increased perineural fluid along the intracorneal optic disc. So if you look at the initial blood investigation, CRP, ESR, the WBC, all the markers are not really high. So IV rocephin was given empirically. So we inserted the immediately because of high pressure with symptoms, the right frontal EVD inserted. Again, protein not high, glucose 4.1. Okay, but anyway, we started anti-TB. Okay, we don't want to repeat the first round. So CSF adenosine, the elimination activity 0.4 not high. TB PCR, again negative. MEN2 test negative. Quantiferon indeterminate. So all the cytology, CSF cytology negative. So day 3, no fever. So when no fever, put a VP shunt, and then during vision, resampling again, the protein slightly elevated, but of course, this is a post-EVD. And day 6, the child actually improved, doing quite well, and discharged a day safe. And then 2 months later, come to follow up, have very good progress, feeding well. Still have some intermittent conversion, especially when focused. Other than that, okay, return to almost himself already. And the 3 months post-discharge, come back again, he back to himself, according to parents. So we still continue anti-TB for whole duration and the whole course. So this time we agreed the child is recovering, but still, are we hitting the correct diagnosis? I don't have an answer, but I think it's better to treat. If not, if let's say we miss it, the neurologic consequently it can be very, very devastating. So conclusions. When you don't have a firm diagnosis, we have to treat based on our clinical findings. Okay, so treat on suspicions. Even though CSF study could be misleading, it can come out to be absolute normal CSF study. And we also have to be very vigilant in terms of the diagnostic test, because we also need to know their sensitivity and specificity. So a negative molecular test cannot rule out TB. And of course, the most important thing, the very close neurological monitoring is mandatory. Whenever there's a deterioration, we have to add on and we have to add fast. Okay, thank you.
Thank you, Dr. Tay, for sharing such an interesting case. I'm sure all of you agree with me. Those cases are very, very difficult. I don't think I will have any idea if I'm managing these patients. I don't think the words of TB will come to my mind. I have to confess. Yeah. All right. Okay. Without further ado, let's introduce the second speaker of the day, Dr. Cheng Dongwei. Yeah, Dr. Cheng is our consultant pediatrician as well as an infectious disease physician in sunmed Medical Center. Dr. Cheng received her basic medical education in Nova Scotia, Canada, and proceeded to work in pediatric units of Nassau University of Medical Center in New York, USA as an internship and residency. She was further trained under pediatric infectious disease under University of Medicine and Dentistry of New Jersey, and after completed her training, Dr. Cheng actually worked in China at a few different hospitals as a pediatric consultant before returning to Malaysia. So without further ado, I think Dr. Cheng is going to bring us a topic on TB meningitis in children, a race against time. Dr. Cheng, the floor is yours.
Thank you for the very kind introduction. All right, and I'm actually, my talk is the continuation of Dr. Tay's cases that we co-managed together during their hospitalization. So my talk will be concentrating on tuberculosis meningitis in children. So the learning objectives today will be mainly cover the epidemiology and the burden of pediatric tuberculosis meningitis globally and also in Malaysia, to help us to recognize the clinical presentations of the tuberculosis meningitis, and to understand the diagnostic challenges and when to treat empirically. Number 4 is to apply the evidence-based treatment recommendation. Number 5 is to identify the prognostic factors and anticipate the outcomes. So there's a recent global mathematical analytical study the study showed that annually around 24,000 children develop tuberculosis meningitis globally, and the mortality rate is very high, around 16,000 deaths annually, up to 67% of the mortality rate. And most of these children that die are actually below 5 years of age. And for the very small number of survivors, a lot of them, up to 70%, actually are living with permanent neurological sequelae, such as hearing, vision impairment, epilepsy, cognitive impairment for life. And very unfortunately, only 54%, up until today, only 54% were actually diagnosed and treated. So a lot of them actually die without treatment, without diagnosis. Now, for tuberculosis meningitis in Malaysia. In Malaysia, children account for approximately 3% of all tuberculosis cases, but they remain particularly vulnerable to severe form of tuberculosis, especially tuberculosis meningitis. Among the pediatric tuberculosis cases, 4.1% develop tuberculosis meningitis, and this represents the highest proportion of tuberculosis meningitis in any age group. And again, children younger than 5 years old, because of their immature immune system, they are at the greatest risk after primary infection from pulmonary TB. Good thing is, in Malaysia, we have very excellent BCG coverage, vaccination coverage up to 99%. And this has helped to reduce severe disseminated TB infection, as well as TB meningitis in infants and children. But overall, tuberculosis meningitis mortality rate is still very high. Close to half of them die during the treatment. And again, remember, a lot of them actually were undiagnosed and untreated. Also, we found that 23% of those TB meningitis patients were actually co-infected with HIV. So it is very important that whenever we suspect TB or manage TB meningitis patients, we should always screen them for HIV at the same time. Also, the studies show that non-Malaysians actually had higher odds of tuberculosis meningitis compared to Malaysian citizens. Now, the clinical presentations of pediatric tuberculosis meningitis, it is often subacute and non-specific. They usually present with constitutional symptoms, such as fever for more than 5 days. They may present with poor appetite and irritability. That is like very non-specific. They may also present with early neurological symptoms, such as headache, vomiting, or behavioral changes. Meningeal signs such as neck stiffness may present, but oftentimes this is absent in very young children, so we may miss this. This may give us a falsely security in our pediatrician, thinking that this is not meningitis. Some of them present with cranial nerve palsies, especially cranial nerve 6, 3, and 7. So a lot of them may present with like ptosis, diplopia, and also facial palsies. As the disease progresses, they enter into the more severe stage, where they will present with seizure, altered consciousness, and if without treatment, they will progress into severe neurological deterioration. And in the advanced stage, they will become like loss of consciousness, coma, and also respiratory distress, failure, and eventually die of TB meningitis. And suspect meningitis. We should always think about TB in Malaysia. Now, who gets TB? What are the high-risk populations that will get TB? Now, children, again, less than 5 years old, they are at the highest risk. And those that are immune, they are at the highest risk, we know, because their immunity is still immature. And then, of course, those immunosuppressed, such as HIV, those that are malnutrition, and also those that are taking the medication that may suppress their immune system. And the patients, pediatric patients that had recent TB exposures or contact are also suspect TB infection, we always need to check for household TB contacts and close contact with TB exposure, because this always gives us meningitis. The pathophysiology of TB meningitis, it is usually begin with primary pulmonary TB infection. It starts with the inhalation of the bacillary into our lungs. The infection starts in our lung and then spread from bloodstream into our CNS and other tissues. Okay, and this will form the ridge foci, which is also called the subependymal granulomas in our brain. And over weeks to months, slowly, this may rupture into the subarachnoid space and release the bacteria and the inflammatory markers into the system, the brain system, causes a vigorous basal meningeal inflammation. And this leads to a lot of complications. And the cranial nerve that go through the basal system will be compressed and causes cranial nerve palsies and the formation of the granuloma. Imaging studies such as the cases that we showed earlier. So it is actually important to know that it is not just the bacteria that is causing the disease progress or inflammation. It is actually the host response, inflammatory response, that is causing the damage and the disease progression in tuberculosis meningitis. So earlier, Dr. Tay already shared with us those cases, the CSF profile, which is one of the most important investigations that we do to diagnose TB meningitis. So the appearance of the CSF is unlike the pure bacterial meningitis, which is usually purulent. For TB meningitis, the appearance can be clear, normal to slightly turbid color. And the white cells is usually within 100 to 500 with lymphocyte pleocytosis. Majority of them are mononuclear cells. But also important to know that at the early stage, sometimes we may see neutrophil predominance, which may give the false impression of bacterial meningitis. Glucose in the CSF is usually low, less than 2.5 millimole per liter. And the ratios for CSF to blood glucose is usually less than 0.5. Protein is usually elevated within 100 to 500 milligram per deciliter. But it is also important to know that these findings are non-specific. We see some of our cases were actually with total normal CSF profile. But at the end, when we keep repeating the LP, keep repeating the CSF, we eventually confirm that those are TB cases. So when we have patients that we are managing, patients that we suspect TB, we should always repeat the LP to get the serial CSF profile to look for TB. For neuroimaging studies in tuberculosis, MRI is the gold standard because it is very sensitive. We often see basal meningeal enhancement, which is the most characteristic finding in in the brain. Also the cranial nerve enhancement, often seen in patients that present with cranial nerve palsies. When in facilities where MRI is not immediately available, we can use CT, but it is not as good, less sensitive than MRI. But it can also sometimes detect the hydrocephalus, the infarcts and tuberculomas in TB cases. So during the cases that Dr. Tay shared earlier, besides TB, even though we start empiric TB treatment, we always need to think about some other differential diagnosis. So during the workup, we do not just fix our mind in TB. We look for other infectious and non-infectious causes as well. For infectious causes, things that have share the similar pictures include cryptococcal meningitis, some partially treated bacterial infection, viral infection such as enterovirus, HSV and varicella virus, fungal infection, especially if we are dealing with someone that is immunocompromised. We should always think about all these not so common infections, but can share the same pictures like TB meningitis. They often have a chronic subacute picture with chronic lymphocytic finding in the CSF profile. For non-infectious causes, etiologies, we should look for CNS malignancy such as leukemia, lymphoma, neurosarcoidosis, even though it's rare in children, but there are some case reports that show that present neurosarcoidosis in children that present with very similar presentations, just like TB meningitis. Other non-infectious causes would include autoimmune inflammatory, as well as drug-induced aseptic meningitis. So, diagnosis TB meningitis is a very challenging thing because all currently available diagnostic tests, they have very limited sensitivity. For example, you can see here, the AFP medical advanced test. We have gene expert, MTB, rifampin, PCR. This is to test for, not just to detect TB, PCR, we also can detect for rifampin resistant tuberculosis. But the sensitivity is only 39 to 56%. Still miss half of the TB meningitis or TB cases. A more advanced test called Gene Expert Ultra. The best sensitivity is only up to 77%. Okay, so even with the best test, we still miss the clinical pictures, neuroimaging studies, the CSF profile, as well as the diagnostic testing when we adjuvant diagnostic tool that has been used worldwide, including Malaysia. In the few cases that we manage here, we also use this test to help us, but we found that so far it. This table is to show you the Gene Ultra performance. The two studies that were done in two different populations. The first study was a Vietnamese study. These patients' populations were all HIV, mostly. Most of them were actually HIV positive patients. Then the sensitivity of Expert Ultra test is much higher, 76.5% as compared. populations, the same test, why is there a difference in the sensitivity? The main thing is because for HIV patients, their microbiology burden is much higher because of their low immune system. So that shows that in the normal immunocompetent patients, because of the low microbes burden, so usually the PCR test, even with the most advanced, the best study that we have so far, the sensitivity is still not very good. So this is just to show you the 2 patients that we did using the shotgun metagenomic next generation test. As you can see, the first patient here, see, many bacteria were detected: Pseudomonas, Staphylococcus, epidermidis. All these were actually the contaminants. They were just, nuisance. They were not treated for Pseudomonas, but they continue to improve. They were also not treated for what we were trying to look for, TB, no, it was not in here. Remember, there was one case that we did the MOTT test. It was positive for NTM, non-TB. So we wanted to use this to confirm, but unfortunately, I think this was this patient. Unfortunately, in this shotgun metagenomic study, we did not see TB, we did not see MTN. So at the end, what we did was, in that patient, during the intensive phase, we had to continue with both TB and also NTM medication, because we cannot confirm what is what. Okay, but fortunately, the patients improve. This is most important. So my talk is mainly focused on why it's so important to treat TB and to diagnose TB early. Why timing is so important. Because if you delay the diagnosis, the disease progress, and eventually patient die. So when manage TB meningitis, you always need to diagnose early. You have a high index of suspicion, and you need to start treatment early, even without the confirmation of TB meningitis. So again, outcome depends very much on how early the treatments were started. And if we do not start the treatment early, as the disease progress, when the patient develop into the advanced neurological injury, it is often irreversible. Okay. So one of the greatest challenges we see now that in TB meningitis is that it begins with very, very non-specific symptoms. And patients typically present with just the constitutional symptoms such as fever, headache, vomiting, that may take up to a week before we really see the true TB, picture. So, and also the neck stiffness may not be present during the early stage. So again, this is just to highlight that how important it is to always think about TB meningitis when we are dealing with patients that present with the similar pictures. Always think about TB when patients present with more than 5 days of fever or headache and vomiting. Always need to think about TB and start doing a lumbar puncture if you do not have a clear diagnosis or if the patient does not improve. I think I've already talked about this earlier. Basically, it's just to show you that there's a study done. It's a 40-year retrospective cohort study done, and found out that from the time of symptom onset to lumbar puncture, if there's a delay, then you will increase a delay from 7 to 15 days, or the treatment delay from 11 to 18 days, the 1-year survival rate will drop from 85% to 47%. Again, stress the importance of early diagnosis and early treatment. So again, do not wait until the confirmation of microbiological confirmation, because it takes weeks. So when you suspect TB, when you see a patient with the symptoms, with TB exposure, living in Malaysia endemic area, immunosuppressed especially, age less than 5 years old. If we suspect TB, just go ahead and treat. And then at the same time, look for other, do some other workup to look for some other reasons, such as the one that I mentioned earlier, infectious or non-infectious causes. What else? I think we mentioned this already. So now, move on into treatment. Treatment, we have intensive phase, followed by the continuation phase. And also very important, we need to use corticosteroids as an adjuvant therapy to reduce the inflammatory response, inflammatory injuries in patients with TB meningitis. And then supportive care is also very, very important because they do have a lot of issues. Some of them need to be intubated. A lot of them has hydrocephalus, or they require for severe disease they require ICU, which my colleague Dr. Olive is going to talk about the next talk. Okay, all right. So the treatment regimen. So for the intensive phase, we start with 2 months of intensive phase. The all four drugs therapy that I think most of us here already know. Isoniazid, H, rifampicin, pyrazinamide. And in adults, usually use ethambutol, or in non-TB meningitis TB cases, we use ethambutol. But for TB meningitis, instead of ethambutol, which has the poor CNS penetration and also some issues with eye problem, optic neuritis, monitoring issues, ethionamide would be a better drug of choice. So nowadays, most of the guidelines recommend ethionamide to treat TB meningitis during the intensive phase, 2 months of intensive phase for TB meningitis. Now, after the intensive phase, the continuation phase is usually a minimum 7 months to 10 months, depending on the disease, the clinical progression. Usually the 2 drugs that we use would be isoniazid and also rifampicin. So total treatment will be around 9 to 12 months. And also it's important to know that during the treatment that we might see paradoxical worsening of the clinical progress when we first started the treatment, such as some of the cases that we saw earlier. So some patients, we may not be able to start oral route directly because all these medications are oral medications. One of the cases that we deal with were having GI bleeding. We just couldn't ensure that there was good absorption from the GI tract. So we had to look for some alternatives, IV and IM parenteral alternative formulations. So for isoniazid and rifampicin, if the child cannot tolerate oral, we can use IV. But for pyrazinamide and ethionamide or ethambutol, there's no IV form available. So in 2 of the cases during the earlier stage, we actually had to use some alternatives. We still use isoniazid and rifampicin IV, but then we need to use amikacin, levofloxacin, which is off-label use in children. And in cases where suspect highly resistant TB meningitis or TB cases, linezolid IV would be another form that we can use. But if possible, even if a child cannot tolerate, but if possible, we still put in NG tube or OG tube to make sure that, because this 4 drug, the all 4 drug would be still the gold standard at the current guidelines. So corticosteroid use in TB meningitis, we always need to start steroid together with the TB medications. This is to reduce the host immunological response. Sorry, I'm over time. All right, okay, so anyway, yes. All right, so yeah, you can see this is the tapering schedule. All right, so I think here is during the treatment, we should also monitor the patient for their liver function test, monitor their eye, and also, as Dr. Tay mentioned earlier, we should also repeat the lumbar puncture, the imaging studies to make sure that the patient continue to improve. So here, I'm going to skip all this here, and probably Dr. Olive will share during her next slides. So I think that's it. Thank you so much for your time.
Thank you so much, Dr. Cheng, for the very comprehensive overview on this TB meningitis, its etiology, monitor, diagnosis, and management. It's really a good revision for all of us. Thank you so much. The last speaker of the day, we have Dr. Olive Lee Pei. Dr. Olive is our consultant pediatrician as well as our pediatric intensivist in Sunway Medical Center. She was trained as a pediatrician and acquired MRCP-CH qualification back in 2015. She further trained in intensive care in Sarawak General Hospital, National Heart Institute, Hospital Tunku Aziza, as well as Birmingham Children's Hospital between 2018 till 2022. She also has involved in various research and projects, including audit in TPN in NICU, quality of life on family with children diagnosed with malignancy, CVVH in myocarditis, as well as traumatic brain injury. So today, Dr. Olive will bring us on recognizing neurological deterioration when even minutes counts. The floor is yours, Dr. Olive.
Thank you for the kind introduction. Good afternoon, good evening now, everyone. I think you have listened to the whole hour on two excellent lectures on the diagnosis of TB, how difficult it was, and also how to treat it. So as a pediatric intensivist, my role is different. I'm usually not the first doctor to see these children. I'm usually called when things have changed or when parents quietly ask, is my child gonna survive? And today, I hope that I will be able to change this mindset whereby PICU should not be called only when the disease declared itself. To know when you should involve your PICU colleagues and how to bridge the care between primary care, emergency department, ward, and also intensive care. I have nothing to disclose except that some of my slides were AI enhanced for educational purposes, and also all the recommendations are based on the recent literature and my own clinical experience. So these are the learning objectives by the end of my talk. I hope that you will know when to escalate early neurological deterioration to the intensive care, to know what are some of the basic neurocritical care principles so that Dr. Cheng has also elucidated this theory. TB meningitis is not just another bacterial meningitis. It is important for us to have this change of mindset because it then will change how we manage TB meningitis. Most of the common infection is caused by the bacteria itself. But in TB meningitis, it's very different. The tuberculosis infects the host, but it is the cascade of inflammation that continues to drive injury. And therefore, it is very important in TB meningitis, there should be a balance between controlling the inflammation, getting some time for the anti-tuberculous medication to work to kill the bacteria, and at the same time, control the raised intracranial pressure and also manage the complications. We tend to think that TB meningitis is uncommon, but based on the previous lecture, we know that the data shows us otherwise. As healthcare professionals who deal with children, and especially when we see sick children, every one of us will see at least one TB meningitis in our whole career. We can see that TB meningitis continues to be a disease with very high mortality and morbidity. But the question that matters most to us is not whether if this child survives, but instead we should start asking, can this child go back to school? Can this child continue to play with their siblings? Because in TB meningitis, it's not all about survival. Many children who survive, they end up needing lifelong rehabilitation. They are not back to their previous developmental trajectory. And our role is to ensure that they survive with good quality of life. So this slide has beautifully summarized the whole pathogenesis. The infection starts with the hematogenous spread, and it reaches the meninges, and there it forms the granuloma. When the granuloma ruptures, that's when it creates an inflammatory cascade. And from there, 3 complications arise. Because of the inflammatory exudates at the base of the brain, it obstructs the CSF flow, and this creates hydrocephalus. The inflammation leads to vasculitis, and this causes infarction, stroke. And because of the hydrocephalus, it drives the cerebral edema, and that's when we see patients coming in with poor neurological state. You can see here from this pathogenesis, the whole clinical presentation of the patient comes in progressive stages. In pediatrics, children almost never present immediately with catastrophic state. They don't suddenly deteriorate. They always whisper before they scream. But unfortunately, we tend to only hear the screams. So in TB meningitis today, I would really like to highlight to you that they deteriorate in stages, just like the traffic light color. They start off with some subtle signs, and then they have some more serious signs before they catastrophically have reduced in conscious level or papilledema, but this is at the point of no return when the brain has run out of time. We would like to catch the child in the early neurological decline when the symptoms are still subtle and reversible. And this is where the window of opportunity, and this is the main bulk of my talk today. This is probably the most practical slide because this is what I apply in my own practice on the neurological examination pathway in children with suspected TB meningitis. Notice that behavior comes before conscious level. Many a times, these children are just not themselves. They are not keen to play, they do not want to have their special food, or they simply do not ask for their special toys again. And parents are usually the first people who recognize this. They will come to you and say, "Doctor, my child is not himself." This sentence should always trigger you to look at the child further. Then next comes to conscious level. Many of us will tend to think conscious level means GCS. But remember, GCS was never designed for toddlers. Instead, observe their interaction, observe their eye contact, observe their speech. All these observations of their conscious level means much more than a single numerical score of GCS. Then, of course, in TB, cranial sign that we see in raised ICP. So in any child that present with isolated eye sign, never dismiss them. Instead, re-examine them, think. By this time, the brain has already been severely damaged. I would rather prevent the child from coming to this stage. And on top of all, trending is very important than just a single neurological finding, because trending is like giving us a whole picture, a movie picture, whereas a single neurological finding is just giving us the whole picture. So this comparison slide, I'm just repeating again two of the patients that Dr. Tay has illustrated earlier, two of the patients that have been managed by us. And this comparison slide is to remind us that TB meningitis presents differently across ages. So a toddler can't speak. Instead, they can have non-specific signs. This child can have vomiting and poor intake, and parents will just complain that he is just not himself. He's not keen to play. He used to be a very active boy. Whereas the older children are more verbal. They can localize their symptoms much better. So he can tell us he's having headache, he's having neck pain, and of course this child also had fever. These two children have symptoms that suggest raised intracranial pressure, and of course they were escalated early. These symptoms were picked up, and at the same time, there are signs that are of concern. The younger child had new onset of bilateral convergence screen, and the serial monitoring in the ward shows a new hypertension. The older child continues to have dropped in conscious level. Remember about trending is better than a single snapshot. So if a child has been with a GCS of 13 sitting in the ward for the whole week, it will not be as worrying as a child who had a 15 GCS and dropped to 13. So these were the two children, one child with cranial nerve abnormalities and another child with dropping GCS and had himself, and we had to intubate him. So I want to connect the clinical examination to the scans. Yes, scans give us extra confidence in diagnosing TB meningitis. But let's see why is it so important to have serial neurological examination. Remember the toddler with the new squint, with some symptoms of raised intracranial pressure. He had his MRI done. His MRI showed CSF, hydrocephalus, but there were no seepage, CSF seepage. So should we intervene immediately? Is the intracranial pressure high? These are the clinical questions that we often ask ourselves. And what will we usually do? We'll get the ophthalmologist, dilate his pupils, look for papilledema. But once his pupils are dilated, we know that we will lose that 4 to 6 hours of window to use the eye sign as part of the monitoring. So instead, in the intensive care, I have the privilege of POCUS to look at any raised optic disc. So this child has a raised optic disc. So despite the MRI not showing CSF seepage, a neurosurgical consult was done and an EVD was inserted. For the older child, he was intubated. He had a drop in his conscious level, and the MRI showed hydrocephalus, even though it was not a super exciting hydrocephalus. Consultation, and remember, mind this, that I did not say early surgery, but I said early consultation, because if any of these children deteriorate at 12 midnight, everybody has a plan. So both of them had EVD inserted. During the EVD insertion, CSF flow was under pressure. So this means that all this deterioration was not theoretical. The pressure was real. Every clinician here will probably be in the same phase as us. Diagnosing TB meningitis was never easy because most of the investigations will come back negative. It is not easy to have a characteristic CSF study. PCR may come back negative. MAN2 can be negative. TB culture takes too long to be back. And remember, the disease is paucibacillary. It is the inflammation that drives the neurological deterioration and causes these symptoms. So, in diagnosing and treating TB meningitis, it requires a very high degree of suspicion. Sometimes it's just guts to start anti-tuberculous therapy even before microbiological confirmation. So again, I would like to highlight here that managing TB meningitis is all about a balancing act. We are buying time for the anti-tuberculous therapy to work and at the same time control the inflammation and try to prevent the brain from getting injured. The first injury is unavoidable, but secondary brain injury is preventable. And there I would like to highlight what are the signs that will help you confidently know that these are early signs of deterioration. Many a times I'll tell my junior colleagues, don't try to remember guidelines. I'm not expecting you to remember all these 9 red flags, but remember the child. Look for any change. If there is one significant change, even if it's single one, but it matters, okay? If there are a few changes, then you know, you probably have to patients again. This is a flow chart of how they have progressed. So of course, they have some signs and symptoms which result in early escalation, both for medical care, intensive care to protect the brain, and also for early neurosurgical intervention. And both had an EVD inserted because intracranial pressure sometimes, despite medical treatment, cannot be reduced. And both patients had a good outcome without any neurological deficit. They went back to school, they went back to playing with their siblings. So these are the 3 fatal mistakes that we should not be taking into account, be doing. We should not be waiting for a confirmatory CT scan or MRI. We are very privileged here that our MRI scans can be done early. And we should not wait till the GCS drops till 3. And we should never wait for a papilledema. So by escalating, you may be asking yourself again now, when should I call my PQ colleague? If you have that question in mind, it's probably you have just answered your own question. If you have any doubts, call. An early referral may not necessarily mean that the child will end up with a PQ admission. It just means shared decision making. And I would prefer to discuss a case early when the child is still talking, rather than receiving an urgent call when the child already had a respiratory arrest. So in neurocritical care, when we talk about ICU, everybody thinks about fancy monitors, fancy machines. But in reality, it's just serial neurological examination and a series of small acts that are done together. So I would like to call these neurocritical care principles as a brain protection bundle. We always start with ABC as well, airway. Intubating a TB meningitis isn't a failure. It's about brain protection. Remember, the brain hates hypoxia. So by intubating a child who is getting weaker or seizing, you are protecting the brain by ensuring a maintained oxygen delivery. Try to have a good PaO2 on your blood gas. And next is carbon dioxide. Hyperventilation is never a brain protection bundle. remember this, because creating hypocarbia can reduce the ICP temporarily. This is just an urgent reaction to raise ICP while you are still arranging for other methods. So hypercarbia can only be done transiently, but it is not for a long period of time. In C, we are talking about brain perfusion. Remember, we must try to optimize the brain blood flow. And brain blood flow is all about blood pressure and intracranial pressure. Most of the unit may not have an ICP monitor, and so we must ensure that there is good blood pressure. Focus is very close to my practice, so I'm using a lot of ultrasound to look at the brain blood flow to adjust the inotropes to ensure the brain perfusion is optimum at all times. But of course, increased intracranial pressures can be relieved by just adequate sedation, treating every fever appropriately, because fever will increase cerebral metabolic demand, and try to treat seizures as much as possible. Continuous EEG may not be available in every unit again, but seizures can present as, a tonic-clonic movement or just simply tachycardia. So again, serial neurological examination and monitoring is important. So of course, I should not forget what you can do, which is elevate the head and up, make sure the neck is in neutral position to prevent increase in the intracranial pressure. But of course, some of these measures that I have explained earlier have some limitations. If the ICP continues to rise, then we need to consider the usage of hypertonic saline, 3 to 5 mL per kilo over 15 minutes, and also, of course, early surgical intervention for possible EVD placement to drain the hydrocephalus. So if I were to let you snap a picture, this will be it. This is the checklist for the brain protection in the intensive care, which can also be instituted even in the ward or the emergency care. So in future, of course, intensive care is all about serial neurological examination, precision care, and also individualized care. And that's when point of care ultrasound comes into hand. Point of care ultrasound is not going to replace a CT scan or MRI, but it allows us to manage our patient's intracranial pressure with more precision, and it is a good bedside tool to give us more confidence. Today is not the avenue for me to explain about transcranial Doppler and also optic nerve shift monitoring with the ultrasound, because this is a lecture all by itself. So I come to the end of my topic. I know everybody is tired, and in every conference, I know there are many slides. I don't expect you to remember all of it, but I think everybody will remember one message, and I will leave you with mine. So when I started training, I used to think that TB meningitis is another infection. But as I move on, I realized that TB meningitis is actually a race against secondary brain injury. So tomorrow, when you return to your clinic, to your ward, or to your hospital, I hope you remember the 2 children that I've highlighted. Okay? Remember a child, when they have no interest like usual, they do not want to play. When they have new cranial nerve signs, or when something changes, try to recognize it early, escalate to the intensive care so that you can protect the brain early. The management of TB meningitis doesn't end with anti-TB medications, but it continues thereafter, every hour, with your examination, with every referral, every escalation, every neurosurgical referral, because with all this, then only we will be able to give these children a better chance of not just survival, but returning back to their previous life. So with that, I thank you. This was one of the children who came to us. And if any of you are interested in learning POCUS, you can join us this December. And there I will be speaking more on optic nerve shift monitoring and also transcranial Doppler. And with that, I thank you.
Okay, thank you very much, Dr. Olive. Kindly remain on stage because our next session is actually the panel discussion. We would like to also invite our other panelists, Dr. Cheng Tong Wei and Dr. Tay Chi Kiap, as well as our moderator, Dr. Ng Rui Teng.
Okay, thank you. I'm sure all of us have a very interesting session on this topic of TB meningitis. And many of you have a lot of burning questions on these topics to all our distinguished speakers. So before I carry on, it's a question posted here. Is there any question from the floor that you would like to ask? I think just now, Dr. Shuming, you have a question you already asked. So I think you should share the question with the audience, whether those 4 TB meningitis patients you managed, whether they have BCG scars.
They do have. Yeah, they have a BCG scar.
All right, so now, is it no longer significant? Can I?
It is a separate test. You have to specifically request for CSF chloride. And if I'm not mistaken, it was outsourced for our center.
Thank you.
We did do for the 2 of the patients, both are all normal. And then the other one, we use a ADA.
All right, thank you. Any other questions from the floor before we proceed with the patients posted on the web? No? Okay, let's discuss the first patient. So the first question is, for the fixed drug combination, either Accurate or Accurate 4 for TB or latent TB in children, do you go up to the maximum 5 tablets daily or only in active TBs, assuming the child is above 70 kilo? Oh, 70 kilo for a kid is pretty big. It's like adult's age. Yeah, so, yeah.
There's maximum dose. So I usually, if it's heavy obese children, I usually just use the adult dose. Every time when we calculate dose, we need to look at the weight, and when it reaches maximum dose, we just stop there, adult dose.
Right, thanks. Thank you for that. Oh, how many percentage of BCG prevent TB meningitis?
Oh, I don't have the data. Maybe I'll go search AI. But in developing country like Malaysia, BCG does protect a lot of children from disseminated and meningitis. But again, it is not 100%. It does reduce the severity of the infection, but it is not 100% protective.
Definitely. So the next.
Yeah, yes, contrast must be, when we talk about infections, the contrast recommended. So we want to look for any inflammation, rectal meningeal enhancement. So for MI, we definitely need a contrast. And even though sometimes you look at there's a signal changes, we have to see these are all ring enhancing, non-ring enhancing. So it only can be picked up from contrast. So if you suspect infections, always order MI with contrast.
Yeah, we always do that. MRIs with contrast. Okay, so correct me if I'm wrong, I'm not so sure about this question, but I read it out. Can web clot in CSF be the most likely place to be find tubercle bacillus in suspected TB meningitis?
Recording stopped.
Web clot. Web clot in CSF. I suppose CSF.
Usually it's clear. In TB meningitis, the CSF invariably are clear. They are not cloudy. When it's cloudy, then this is bacterial infections.
All right. Okay. Thanks. So next question. I hope they answer the questions. Yeah. All right. Next, if a patient is Down syndrome, body weight more than 40 kilos, unable to tolerate loose pills during intensive treatment, can we choose to crush Accurate 4? Can it be crushed?
Yes,
Yes.
we do crush the tablet. Yes.
Can, no problem.
Yes. And a lot of time when they're unable to tolerate, just use NG tube. That's with case number 1, we use
alright.
NG tube. Initially, that was a very spoiled child, very manja.
All right.
Mommy always said it has to run from like 5 minutes to chase her to take the medication. And that's the reason she defaulted the medication. That is why we put in an NG tube, and the child eventually learned that you either take it or you endure with the NG tube. And after 1 month, she came back and mommy said that she will sit there nicely and take the medication she learned.
Excellent.
So
Thank you.
if cannot tolerate, always put in NG tube.
All right. Okay. I think we have come to the end of almost all the questions. Okay. One last question, not to say really related to the topic. The audience is asking whether they can get a copy of the slides. If you don't mind, you can share the slides in the PDF form to the audience. All right, I think I have finished all the questions that's posted here on Slido. Any other burning questions on the floor? Anyone would like to ask any other question, anything to clarify? Burning questions? No? If that's the case, I think we should close the session. And thank you very much for all the distinguished speakers and all the questions. We have learned a lot from all of them. Thank you so much.
Testing? Okay. For all the speakers and moderators of that slot, kindly collect your token of appreciation. Okay, thank you to all our distinguished speakers for sharing your valuable insight. And thank you, Dr. Ng Rui Teng, for moderating the session and facilitating such an engaging discussion. Ladies and gentlemen, we have now come to the end of day 1 of the Pediatrics Without Borders Symposium 2026. Thank you for your active participation and engagement throughout today's sessions. Before we conclude for today, we would like to share a few important reminders regarding CPD points and e-certificates. For our physical participants, our team will be scanning the MMA app to record attendance for CPD points, and this will be carried out at the end of day 2. For our virtual participants, kindly complete the feedback form so the team can proceed with issuing your CPD points manually. For both physical and virtual participants, please remember to complete the feedback form to receive your e-certificate. All these arrangements, as mentioned, will be carried out tomorrow evening. As for parking validation, for those who haven't received the validation slip, kindly get the slip at the registration counter. And for those who already have your validation slip, kindly head to customer service, Tower B, ground floor to validate your parking. Thank you again for joining us today, and we look forward to welcoming everyone tomorrow.
you.